Hello everyone, I'm Dr. Jack West. I'm a medical oncologist at Swedish Cancer Institute here in Seattle, and I'm also the founder and president of Xrays, Global Resource for Advancing Cancer Education. Welcome to our OncTalk today. This is part of a series of events that we're doing in various locations around the country on various topics. And today's is on the timely one of the concept of adding local therapy in the setting of stage 4 non-small cell lung cancer, which is an area that historically has had systemic therapy as the cornerstone with a very limited role for local therapies, that is, treatments directed at a specific target like using radiation or surgery. And this has been dynamic. We've gotten new data that support the concept of using local therapy in the setting of metastatic disease in certain situations. And part of that has been changes in our systemic therapy and how well it works. Part of that has been in the increased ability of radiation and surgery to be useful with minimal toxicity, minimal side effects and morbidity, and very good efficacy. So we have a great faculty today, and that includes Dr. Vivek Mehta, who is on the end here and is a radiation oncologist here at Swedish Cancer Institute who covers a lot of areas but has a significant expertise in managing thoracic oncology. After that, we have Dr. Puneeth Iyengar, who is an assistant professor at UT Southwestern in Dallas and is a radiation oncologist who is going to talk to us about some of the emerging data on the role of local therapies and improving outcomes in our patients with metastatic disease. And then we have Dr. Vallieres, who is a thoracic surgeon at Swedish here, who will talk about the role of surgery and the increasing ability to do surgery with minimally invasive techniques and a very low risk. And then I'll talk about the changing landscape of systemic therapies and how that is kind of setting the stage for the greater utility of local therapies. I'd like to thank our sponsors, who are AstraZeneca, Lilly, Celgene, Genentech, and Swedish Cancer Institute as well. Thanks very much. And with that, we will start on our program. I'll mention also that we do allow for questions for those in our live audience. If you can take a notepad and a pen and please write them, you can give them to one of the staff here. We'll be able to incorporate that into the Q&A. And for those who are online, I'd welcome you to use the chat function to submit a question. We'll be able to see those and have this be part of an interactive discussion. In addition to the live event today, we're also going to be editing this and putting this onto our website and YouTube channel, etc. So this will be available. Anything you don't get the first time or just want to go back and watch over and over because it's that good, feel free to go back. There's many opportunities to see it again and again, share it, etc. So this is going to be a really timely discussion. And with that, I'd like to turn it over to Dr. Vivek Mehta, who's going to be talking about newer techniques in radiation that make it particularly feasible and attractive to pursue local therapies with radiation in the setting of stage 4 disease. Thank you.
Well, thank you, Jack, for inviting me today. It's a pleasure to get to talk to people about what's going on in radiation oncology, particularly with these new technologies. I think many people know that we've been using radiation to treat cancer for a long, long time. I think what people sometimes lose sight of is that the change in radiation technology is basically of the magnitude of, imagine I was given this lecture today and I had to point to something on the screen and I was using a flashlight to point to that on the screen. What you'd see is a big flash of light over that whole screen, wouldn't you? But today, we don't use a flashlight to point to something on the screen. We use a laser pointer. And that laser pointer is a small dot on the screen. And it doesn't matter where we stand, it's always that small dot. Our ability to paint and point the dose of radiation has changed dramatically over the last several decades, but it's accelerated particularly over the last 20 years. So how has radiotherapy gotten different and how has it gotten better? Well, we're more precise because we have better imaging. We can actually see where the target is to an extent that we never saw before. Our ability to plan that radiation, meaning that we can take a computer and figure out where to point that laser pointer in terms of targeting, has gotten better. And then our ability to actually deliver the radiation to a patient that's coming into our department has gotten significantly better. Now, how has it gotten better? It's gotten better because we have so many more tools in our toolbox. And we're going to sort of march through some of the common tools that people hear about, Protons, Gamma Knife, CyberKnife, tomotherapy. These are a lot of the common terms that patients hear about today in terms of radiotherapy. So how does our imaging get better? Well, in the old days, we could see and feel the tumor because sometimes it was so big it was coming through the skin or something you could palpate, but didn't actually know how deep it went or what the edges were. As CTs got better, we got a three-dimensional understanding of where that target was. As we got PET CT scans, which are functional imaging studies, we understand the biology and the intensity of uptake, where the cancer is on the scan to a greater extent. We now incorporate all of that imaging modality to basically figure out where that tumor is, where it starts, and where it actually stops. In addition, it's very routine, particularly in the setting of lung cancer, to understand that the tumor is sometimes moving, okay? In lung cancer, it's moving because as you take a breath in, it's moving up or down. And about 20 years ago, I'm kind of old now, okay? I was in training. I was talking to one of my mentors, and he told me the cancer always moves up and down 1 centimeter, okay? Up and down 1 centimeter. So you drew a box, I'm not kidding you, a little box on a film with a crayon and said, I want to aim this radiation at this box because I need to account for that movement. What you didn't know is the picture at your time, did you capture that particular tumor at the top of its swing or the bottom of its swing? And so you just drew that box based on one picture. Today, we never draw a box, but we also never capture the movement based on one picture. A patient coming in for radiation planning will often have what's called a 4D CT scan, which is a CT scan that's done 10 times during a single breathing cycle. So as you take a breath in and a breath out, you're getting 10 simultaneous images of that particular tumor. What that allows you to do is understand where the tumor is at any point during that breathing cycle. It also allows you to understand if the tumor is changing shape during that breathing cycle, because as the lung expands, the tumor might actually be stretched rather than movement. So you get the stretch effect as well as that movement effect. Why is all this important? Because now you can customize and individualize your treatment for a particular patient's tumor during a particular breathing cycle. And that has changed everything in our ability, because if we can target better and we understand where the tumor is, we can really make changes with radiotherapy. So what about targeting? Well, targeting is important because as you aim the radiation, you're often trying to do this balancing act. I want to give as much radiation as I possibly can to the tumor, and I want to protect as much as I possibly can the normal tissues in close proximity. So understanding where the tumor is related to those normal tissues can allow you to then angle the beams from multiple different angles to hit that particular tumor. So we're working on things in the clinic where we encompass the entire motion of a tumor. We're working on things in the clinic where we actually stop the motion of the tumor and treat just during the window where it's at. And we're working at things where we treat where the tumor spends most of its time. Because depending on a particular patient or depending on a particular situation, these things can allow us to deliver a higher dose to that tumor and protect more of the normal tissues. So let's talk a little bit more about how we can actually do that. What are these delivery tools? So we talked a little bit about these different things that we hear about. I'm going to start with something called the Gamma Knife. Okay? The Gamma Knife, and this is sort of a picture of the latest version of the Gamma Knife, is a radiation-producing machine. It uses cobalt sources that are buried into this machine, and it's designed simply to treat the brain. Why did I start here? Because the brain is in some ways, a simple target. It doesn't move. And if you can fix the patient into this machine and triangulate exactly where the cancer is within the brain, you can deliver very, very high doses to any of those targets. Now we know in lung cancer, sometimes the cancer spreads to the brain. What if you could identify those spots, treat them with pinpoint radiation, and have a 90 or 95% chance that that spot is never going to come back and bother you? These are the kinds of things that we can do with pinpoint radiation like this. This is a picture of a patient that is being secured into this device. Their head is immobilized with a frame. The frame is actually screwed into their skull. Small little screws. I see some grimaces, okay, but we give some anesthesia, okay, and the medicine that we give with it puts these patients oftentimes in a beach. They're totally aware, but they're happy during this procedure. And 30 minutes later, 40 minutes on the outset, they've had this treatment. They take this frame off and they go home. They never spend a night in the hospital. Oftentimes the side effects are very manageable and the disease in the brain has been completely treated. And we know that because we're going to follow them with serial MRI studies and watch as this cancer disappears. Okay? So this is a patient treated back in April. This is a month later. Look at the lesion in the brain, okay, that you can actually see there, approximately 2.5 centimeters, disappearing 6 weeks later on the scan. Okay, sometimes it takes longer than this, sometimes it takes shorter than this, but we'll get scans on these patients going forward, and very rarely do we see the cancer come back in that situation. So imagine that, 40 minutes and you're home. Okay. CyberKnife is something else that we often hear about. I chuckle a little bit because I live down the street. I was telling one of my colleagues, I live down the street from my parents. I actually grew up here in Seattle. My parents live about a mile away. You would think that since we know each other so well, they would know things, okay? But it turns out that they heard on the radio about this device called CyberKnife. So just this week, they actually called me up and said, hey, what do you know about this device, the CyberKnife? And so I had to tell them that the CyberKnife is a form of a radiation-producing machine. It's a linear accelerator that is mounted on a robotic arm. Now, I had the privilege of actually working on the prototype of this device 20-some years ago at Stanford. At that time, the robot was taken from the robots that used to build cars in Japan. That was the original robot when it would actually put the stirrups in. And they put this linear accelerator on it. It is quite a bit better than 20 years ago. This device not only produces radiation, but because it's mounted on a robotic arm, it can actually track a moving target. Okay? So much like a fighter pilot in a jet that sees a target that it wants to hit that's moving, it sees where that target is, it locks onto that target, it keeps its firing on that target while it's actually aiming at it. That's what this device is designed to do. How does it do it? Well, it has a series of different tools on it. One is that it has these X-ray detectors that are mounted on the wall and the ceiling. The patients often will wear a vest on them. The vest sends off a signal. So as the patient is breathing, you can track the motion of that chest wall. Inside the patient, we often will put some markers into the tumor. When you put markers into the tumor, as the tumor is moving up and down while the patient's breathing, you can actually detect those markers and triangulate it. And that allows you to keep the radiation machine moving with that moving target. The really interesting thing is that it not only treats where it sees, but it has a predictive algorithm to treat where it's going to be. So it's really like that fighter pilot in terms of its ability to do that. If for some reason the patient were to cough or twist and move too fast, the machine actually shuts off. So it only treats when it's actually tracking and on target. Well, what's really interesting about this device is it took the same principles of triangulation that we were seeing with the Gamma Knife and now allowed us to treat outside of the brain. Remember, the brain doesn't move. So when you secure the brain in fixed three-dimensional space, you know your target's not moving. But in something like the lung or elsewhere in the body, say the liver, or if you have a metastasis in the liver, this is a really good way of delivering that dose of radiation. So here's an example of a patient that has a lesion in their lung. and you can see it on the CT scan, and you see these small little markers that they've been put in next to the tumor. Those little fiducial markers are the markers that the tumor is going to be tracked on using that CyberKnife system. And then once we can see the markers, we can deliver this high dose of radiation with basically pinpoint accuracy to treat a lesion like this. You're going to hear more about the results and where this sort of fits into the world, but for early stage lung cancer, small lesions, or for metastatic disease that's small lesions, we can eradicate that disease as high as 90% of the time. So we're starting to match what you can see in the brain using devices like the CyberKnife to treat these targets. This is a CyberKnife patient that was treated for a disease in their liver, a metastases that had spread from lung cancer, and you can see on serial scans that that lesion that was there gets treated and slowly dissipates over time. So pinpoint radiation, delivering a high dose of radiation to that area, can actually eradicate this disease. Tomotherapy is something else that you might hear about. We've talked about techniques using to treat the brain. We've talked about techniques using pinpoint radiation and tracking. There is a world of treatment that does arc-based treatment. So the idea behind an arc-based treatment, whether it's tomotherapy or some of the newer equipment beyond tomotherapy, is that if you have a target here and you aim all the radiation to that target from one side, everything in front of that target gets a dose of radiation and something behind that target gets a dose of radiation. So it's very simple to think from a radiation perspective. You should divide the dose up and come from multiple different angles. And if you take the dose and you come from 4 different angles, your entry doses have now dropped by 25%, 25%, 25%, 25%, 25%, and the overlap is still 100%. Makes sense, right? Okay. Well, what if you could come from a full circle around the patient? Basically a complete arc, where you're delivering the radiation completely around that arc without stopping. What if while you're delivering the radiation completely around that arc without stopping, you're changing the shape or the energy of that radiation so that it goes to a different depth, and through that particular angle, you're changing the shape of the radiation to avoid a particular structure? What if while you're doing that treatment, you simultaneously or shortly after can treat from another arc, a non-coplanar arc? People often have a hard time understanding what a non-coplanar arc is, and I tell them to think about a basketball. A basketball often has those black dark stripes around it. Each one of those black stripes is an arc of treatment. If you tilt the beam by just slightly and then do another arc, you have a whole nother 360 degrees of angles to come at this. So arc-based treatment offers an opportunity to treat patients in a way that we'd never treated them before. And that's sort of what tomotherapy provides. I have a few more minutes to talk, and I'm going to talk a little bit about protons, okay? So I told you a little bit about my dad. My dad called me about CyberKnife. That was totally the truth, okay? That was 100% the truth. You're not going to believe me, but this morning before I headed out, I had to call and wish my father-in-law happy birthday. His birthday was yesterday, okay? And after we got done with those pleasantries, he asked me about an ad he heard, okay? And the ad he heard was about proton therapy. He lives in Maryland, and there's a lot of buzz about protons since there's a large proton center in Maryland today. So there's a lot of buzz about protons in general, and many of these proton facilities are different than the traditional X-ray facilities. The original proton centers cost somewhere in the neighborhood of about $200 million to build. So they're very expensive buildings. They are built and they house this, this radiation producing, proton producing equipment, and then they have multiple vaults, okay? So why is it that there's a lot of buzz about protons as opposed to conventional X-ray therapy? So I have to sort of show you a little bit of physics to understand why there's interest in protons. So conventional X-rays and everything that we've talked about before has been you aim the X-ray from one source and it comes through to the target, depositing energy along the way to the target and then some energy past the target. And the way that you concentrate the dose in conventional X-rays is you come from multiple different angles to create the overlap being hot. And that's how you minimize the dose around the target. But what if there was a way of producing radiation where only the target saw the dose of radiation and there was no entry and there was no exit? Well, that's the promise behind protons. The physics of protons are that they're a particle. okay? And you accelerate this particle so fast that at a pre-specified distance, the particle basically goes pop and deposits all of its energy, okay? There's very little energy on the way in and very little energy on the way out. This is a cartoon telling you that if your tumor happens to be exactly at the Bragg peak, you'll get entirely all the dose from the protons, okay? If your tumor is not where the Bragg peak is, then unfortunately the energy will be deposited somewhere else, okay? Hence the problem with proton therapy, is that we need to try to figure out how to exploit those physics for the patient's advantage, okay? But in theory, and on cartoons, if you deliver a proton field and an X-ray field and you only come from one angle, the proton field, if the tumor is in the high dose Bragg peak area, is going to deliver less dose to the surrounding tissues. So the promise of protons are, how can we develop the technology that allows us to track the same moving target, image the tumor, deliver the protons from multiple different angles, exploit that Bragg peak so that it hits just where that target is. And as proton technology gets better, we're going to continue to see improvements in our ability to do that with this technology. Okay? One of the big improvements in protons is that the price is coming down. So you can now install a proton machine in the neighborhood of $20 to $25 million, which is quite a bit less than $180 million average cost. As it comes down even further, I think you're going to see more of this technology become more available across the country. In addition, some of the tools that we talked about that are available in these other technologies, like image guidance, tracking a moving tumor, and making sure that you're hitting the target that you want to hit, are going to be built in to the proton machines that will make it even more useful. So I think that there's a lot of promise about this technology into the future. Okay. It's always nice to have people come to Seattle or visit Seattle, but you know, I usually put these pictures here of sunny days where you can look out at the beautiful mountains and the water. But today I thought I would be more accurate to the weather that we normally have in November. Conventional radiation has typically been delivered Monday through Friday over 6 to 7 weeks. And the concept was that you gave a small dose of radiation every day to try to treat the target. And the rationale was that by giving a small dose of radiation, you did enough to damage the cells that were exposed to radiation, but not kill those cells. And the reason that you wanted to just damage cells is because cancer cells have a hard time repairing that damage. So since they can't repair it, they die. Normal cells can repair that damage, and then when you come back the next day, you have healthy normal cells and some cancer cells that have died, and you keep doing that process over and over and over again. That was the whole rationale behind, you know, conventionally fractionated radiation. But what if you could deliver such a high dose of radiation that, and it was just to wherever your target was, that you could actually ablate those cells? You're no longer trying damage, you're trying to kill them or ablate them or get rid of them. Really, really high doses. So the original word for that was stereotactic radiosurgery, or SRS. Stereotactic radiosurgery was basically a word that was coined to deliver such high doses of radiation that you were duplicating what the surgeon could do. And that first word, SRS, or stereotactic radiosurgery, was really meant to be doing it in one dose of radiation and primarily for patients in the brain. So you were duplicating what the neurosurgeon would do with surgery. As we moved that technique outside of the body, we started to use words like stereotactic radiosurgery, body, SBRT. The more recent acronym is SABR. Again, trying to describe the fact that you're pinpointing the radiation from multiple different areas. You're delivering a very ablative dose of radiation. Usually that ablative dose of radiation is delivered somewhere in the neighborhood of 1 to 5 times, depending on how close it is to a structure. But each dose that you're giving to that particular patient and that particular tumor is designed to kill all of the cells. Okay.
So SABR is stereotactic ablative body radiation.
Right.
It's essentially the same as SBRT, just
Correct.
a cooler sounding acronym, correct?
Much cooler.
Yes, right.
Much cooler. And you know, we in radiation oncology have to keep up with the surgeons and the medical oncologists when it comes to the coolness factor.
Yes, no doubt. Okay.